So can I request Dr. Devendra Venkatramani to begin his first talk on dilemmas in treatment with recalcitrant cases? When to switch?
Hello. Very good morning to everyone. I'm very happy to be part of this session, and thanks to the organizers for the same. Um, as Dr. Bhavankure sir described the problem statement, it's really a big problem, and we have to bear in mind that it's not only the size of the problem, but also the magnitude or the extent to which it can affect vision. And diabetic macular edema is the leading cause of visual impairment in a diabetic patient, and it predominantly affects younger patients and those at their prime of economic life. And you can see that also the type of diabetes plays a role. But while the treatment of diabetic macular edema has evolved over the last few decades, there are still patients who don't respond optimally or as we would have really liked them to. And these are some, analysis from the protocol I of the DRCR network. And you can see at various time points, whether it's the first year, 81%, at the end of 2 years, 56%, and at the end of 3 years, almost 40% of patients who still require ongoing treatment. So it's a very ongoing problem, not one with a quick fix as many would like. And, a lot of literature supports this idea that persistence of the macular edema results in lower visual acuity gains. And that's obviously, intuitive when we look at our patients as well, that those who require multiple injections over a period of time keep losing vision gradually, or they don't improve as those who responded well initially do. And here you can also see how the central retinal thickness has correlated with poorer visual recovery in eyes, where the central retinal thickness continues to be in the higher quartiles. So in the past, we've always been treating now diabetic macular edema as an anti-VEGF treated problem, but steroids do have a role as a second line agent, and there are certain specific areas where one could still prefer steroids. In those, we can consider non-responders, in somebody who has a major cardiovascular event in the previous past, in the recent past, or in chronic patients with pseudophakia. But looking at the visual acuity gains with steroids, and this is, data that is now available, and the Maggiore study was the only one that looked at head-to-head data of ranibizumab versus Ozurdex implant, and you can see that the visual acuity gains, unfortunately, with steroids are not as much as they are with anti-VEGF. And here you can see that the anti-VEGF gains have been blunted by the ceiling effect, because they almost, in many studies, they reached the plateau of 70 letters. And we've been practicing this as a strategy for many years, that if a patient does not respond with one therapy, you can switch over. But studies do show that switching over may not ultimately yield a better visual outcome. And these are, comparisons of switching switching over to a dexamethasone implant, or that in combination with anti-VEGF, and there does not seem to be significantly better visual outcome. So we need not even then go into the adverse event profile of steroids. Now, it's not been too long ago that Kite and Kestrel came out with their data on brolucizumab in diabetic macular edema, and you can see the extremely salutary response it had on the central subfield thickness. And of course, it was being compared to the standard of care aflibercept 2 milligrams. And these are the CSFT data persisting into the second year. And the visual acuity gains as well, which were comparable to aflibercept. I think this is well established, but sometimes as clinicians, what we tend to overlook is the number of injections that were required to produce this effect. And in the first year and in the second year, you can see a significantly less number of median number of injections. 7 of brolucizumab versus 9 of aflibercept, and at the end of the second year, 11 versus 15. So that I think is a significant factor. And similarly, the drying ability or the durability of the injections was appeared to be much better with brolucizumab with a fewer number of injections compared to aflibercept. So this is some of the post hoc analysis as well, and you can see that the area under the curve are different for brolucizumab and aflibercept, and significantly so. So the drying ability of the molecule seems to be established against the current gold standard, or what we would have called the standard of care a few years ago. So, with that background, I just thought it would be pertinent to look at some cases that we've had during our treatment of patients with diabetic macular edema with brolucizumab. And I'll very quickly take you through a patient who has been with us for more than 5 or 6 years, and he had already received aflibercept biosimilars in the past. And this was the picture when he presented to us in 2018, and we decided to switch over to a steroid principally for the longevity of effect. And both eyes received dexamethasone implants, and they had a good result, but the patient continued to require intermittent dexamethasone implant treatment almost on a 3-monthly basis. And here you can see over the years 2019, and here you can see in the OCT that there is some media opacity developing, and continued treatment with dexamethasone, worsening of the media opacity, so to the extent that you can't even get the normative values of the OCT. He underwent phacoemulsification when his vision had really dropped to a terrible level, but he regained some vision, and now you can see chronicity in the OCT, which means that these unfavorable biomarkers, prognostic biomarkers like drill, a disorganization of the retinal inner layers, and the skytic nature of the fluid as it has now evolved over the last few years, 4 to 5 years, means that the visual acuity is not getting back to what it used to. So one eye seems to be maintaining vision while the other is continuing to lose vision, and there are these multiple retreatments required. So it was in July last year that we decided now to switch him over to brolucizumab, because he was losing the effect or the advantage of dexamethasone within 3 months. So, that is something that we then really need to think about doing something different. So you can see that with brolucizumab over a 1.5-month period, very good drying, still some recurrence after 4 months, and then repeat injections are going to be required. But the moral, I think, out of this case is that the visual acuity improvements now, if you look at the left eye, although the macula is very dry, the visual acuity has gradually declined to a level that it's not being able to be restored because of foveal atrophy and loss of the retinal architecture. So this is a very a contrasting case where we had this patient who had diabetic retinopathy and maybe a component of very microvascular occlusion over there, and extremely poor vision. And with a single injection of brolucizumab, she improved very well, and she continued to improve, and this is the last follow-up with a very sustained benefit. So I'll summarize all of this, literature as well as this real-world experience into, these few points, that while anti-VEGF does appear to be the mainstay of treatment in diabetic macular edema, we have to bear in mind that persistent edema over many months and years will equate with a poorer visual outcome in the long run. And while we are tempted to start initial treatment with different molecules, and while optimizing treatment may involve switching over to different molecules during the course of the patient's treatment, switching late may jeopardize the visual outcomes, because by the time that anatomical changes have set into the retina, it may just be too late. I think a very important take home is that every intervention that we can reduce is a saving, not only in economic terms, but also in terms of potential side effects and complications for the patient. So if over a span of a year or 2 years or 5 years of treatment, if we are able to achieve favorable results with fewer interventions, I think all of us would prefer that for our patients. I end my talk here, and it'll be a very interesting discussion, I'm sure.
Thank you. Thank you, Dr. Devendra, for highlighting the importance of this newer molecule in the treatment of such recalcitrant cases. In fact, the second case, if we ponder upon, Was it a case of a diabetic macular edema versus a type of a occlusion? And do you mean that even in occlusion cases, it does respond that favorably? Also, comment from sir.
Uh, well, I think I do have some rare experience. It works very well for occlusion cases also. But what is important here is what he highlighted. I think once we get late, I think, and we keep on switching and we should not allow it to come back. Interretinal fluid, that is where the bottom line is. If we are allowing it repeatedly to come, it is going to damage. It is ultimately going to lead to this. That is why we always emphasize that strategy of treat and extend, and somehow having a protocol where we can prevent that. You'll not have from 6/9 coming to almost 6/24. So that is very, very important.
The other point is that often what we are only looking at sometimes are the improvement in terms of visual acuity, but now there is more and more evidence emerging that eyes where you start treatment early and where you do not allow the fluid to stay for longer, over a period of time tend to have a better contrast sensitivity, better outcomes in terms of other visual functions. So I think tackling care of fluid at the earliest and not allowing it to become chronic holds key not only to recovery in terms of the acuity, but also in terms of the quality of vision that's happening there.
Yeah, your question.
Good morning, I'm Dr. Aditi. I have this small question. How do you tackle DMEs in vitrectomized eyes, pseudophakic eyes? That sometimes is a challenge. So what really is your choice of drug in that case?
So at least the half-life studies suggest that anti-VEGFs get washed out much faster in a vitrectomized eye, and therefore one may logically conclude that an Ozurdex implant or dexamethasone implant would offer a more durable effect. The argument against that, especially with regard to brolucizumab, is that, and this is borne out in the real world situation, is that you get visual improvements and you get OCT improvements in 24 to 48 hours. So you are not really now looking at the natural half-life of the drug within the eye, but you're looking at a very rapid penetration into the subretinal space, into the choroidal space, for example, in wet AMD. And therefore, you may have sustained effects even with a drug like brolucizumab, where the half-life may, no longer be relevant.
Thank you. Devendra, that was a nice learning from this particular question.